So first we're going to make sure that our reservoir isn't leaking. The bag inflates completely, so I'm not concerned about it leaking. This green filter here prevents vomit from re-entering the bag. So I'm just going to attach the tubes. I'm now going to attempt to ventilate my patient with placing the mask on his face with a head tilt chin lift and a C grip. I'm going to give one breath every 6 to 8 seconds, assessing for chest rise and gastric influx. So 1, 2, 3, 4, good chest rise. I didn't see any gastric inflation, so I'm not concerned about that. However, if I did think that there was a gastric inflation, I would get my bystander or colleague or myself to apply cricoid pressure. So I'm just checking for the Bodac seal. There's a little black seal in here, so we do have a Bodac seal present. I'm going to put the regulator onto the oxygen tank. And a quarter turn to tighten. Just going to turn it on to check how full the oxygen tank is. For the purpose of this video, the oxygen tank is empty. However, if it was full, the arrow would flick up over here. Just going to turn it off to attach the tubes. Tube just goes under here, attach it to the mask, turn the oxygen tank on, and adjust the flow rate. So for an acute mask, you would have a flow rate of 6 to 8 litres per minute. It's just adjusting the flow rate here. 8 litres per minute. Going to put the mask onto the patient. Now that the patient has received sufficient oxygen, I'm going to take the mask off the patient. I'm going to turn the flow rate back down to 0, turn the oxygen tank off, unattach the tubes. However, before it's safe to take the regulator off, I have to depressurize the oxygen. So I'm just going to turn the flow rate up to 10, and now the pressure's released and it's safe to take off the regulator. So just going to do my operational check first. So while that's in progress, I'll just identify the ET-CO2 tube. Here it is. Just plugs in up here. Usually found in this little side pocket over here. Just wait for the operational check to do its job. Okay, so now I'm going to do a test of fibrillation. Let's go energy select. We do want it in manual mode. So for the purpose of it just being a test, we're going to turn the joules down. Just going to charge it up now. Cool. And now I'm just going to show you how to disarm a charge. Charge disarmed. For the purpose of this this check, we've just got the ECG leads plugged here, not into an actual person. So to change between leads, I go lead, Now we're looking at lead 2, 1 and 3 and change size and leads. Lead changed. Lead size changed. To change the amplitude. There we go. All done. So my patient has a suspected spinal injury. We're just going to run through the nexus criteria to see whether he passes or fails it. Could you please look at the ceiling? Keep your head still. So I'm just going to run my hands down your body, just checking for a neurological deficit. Can you feel that?
Yep.
Yep, okay, squeeze my hands. He's squeezing. Are you feeling any numbness or tingling?
No.
Can you feel my hands running down your legs on both sides?
Yep.
Can you push against my hands? Cool. Pull against them. Okay, no neurological deficit. I'm just going to check for spinal tenderness.
Oh, yeah, that hurts.
Okay, so my patient has some C-spine tenderness. What's the day today?
24th, it's Friday.
Friday? Yep. What's your mom's name?
Elaine.
Okay, so I've determined that my patient does not have an altered mental status. Have you had a beer today?
No.
No alcohol?
No.
Okay, he's not intoxicated. Does anything else hurt?
No.
No distracting injury. However, he has failed the nexus criteria because he does have some spinal tenderness. So I'm going to put a collar on him, but first I'm going to measure it. So, yep. So I've just measured the distance between his jawline and the beginning of his trapezius. Was distance of 3 fingers. So Jacob has a short neck. I'm just going to ask a colleague to come and stabilise his neck while I put the collar on. Cam, could you just hold his... How's that feel, Jacob?
Yeah, good.
Yep. Cool. Thanks, Cam. So this is my patient, Jacob. He has a tib fib fracture. So before I do anything, I'm going to expose his wound. Slowly roll his pant legs up. It's important to assess for cardiovascular and neurological integrity before and after splinting. And check for cardiovascular integrity first, checking cap refill on both feet to make sure that they're equal. His cap refill's fine, checking temperature, all normal, pedal pulse. Good strength on both sides and the colour of both feet are the same. I'm just going to check for neurological integrity. Can you please wiggle your toes, Jacob? You can wiggle his toes. Are you feeling any numbness or tingling in your affected leg?
No.
Does that feel normal on both feet? Can you feel my fingers there?
Yep.
Okay. So he's neurologically intact. Now before I go to splint Jacob's leg, I'm going to ask him if he wants any internox. The contraindications of internox being if he's unable to obey commands, has a suspected pneumothorax or a suspected bowel obstruction, or has been scuba diving within the last 24 hours, I cannot give him internox. So I've used a cardboard box as a splint here, and I've just taped together at the end. I'm just going to chuck some padding in to make sure that it's more comfortable for my patient. Just going to ask my colleague to come in and stabilise his leg while I slide the splint under, just to minimise pain to Jacob. Yep. That's good. So the splint's under his knee joint and it's protecting his ankle joint. I've just used a triangular bandage here to provide more mobilisation of Jacob's rib fracture. Just tightening the bandage now, Jacob. I feel some pain. Just one more time. Okay, so now that I've splinted Jacob's leg, I'm just going to reassess cardiovascular and neurological integrity. Assessing cardiovascular integrity. Cat breathall's normal in both feet. Temperature, colour's normal. Checking pedal pulse. Pedal pulse found in both feet. Neurological integrity. Can you wiggle your toes for me, Jacob? Yep, all good. Feeling any numbness or tingling?
No.
Can you feel me running my hands?
Yep.
Yep, and it feels normal?
Yep.
No difference? Cool. All good. So my partner and I are responding to a cardiac arrest in the mall. The environment, there's quite a few bystanders around, but I have rung the police on arrival to come and help me manage the bystanders and any unpredictables. The traffic that I'm worried about, obviously, is the bystanders that are already here and any people entering that mall that aren't aware of the cardiac arrest. My PPE, Jacob and I are both wearing our gloves, goggles and boots. It's now safe for us to approach the scene. Sir, can you hear me? Open your eyes if you can hear me. Not responding to verbal stimulus. Not responding to painful stimulus, so I'm going to check his airway. He's not vomiting, he doesn't have anything obstructing it, so I'm going to check for breathing for 10 seconds. He's not breathing, Jacob, can you get on the chest, please? So I'm going to place the AED pads on his chest, just making sure that he does not have any jewellery and that his chest is dry. R49 requesting for an R50.
Analyzing heart
Can you please
rhythm.
get off the chest, Jacob?
Do not touch the patient.
Stand clear.
Shock advised.
Shocking the patient, stand
Charger.
clear.
Stay clear of patient. Deliver shock delivered.
Back on the chest, Jacob.
Pause.
So I'm just going to insert an
Start
OPA to protect
CPR.
his airway. So Jacob, when you get to when you get to 25 compressions, can you just let me know so I know to ventilate him when you get to 30?
Yep.
Turning the oxygen on.
25, 26, 27, 28, 29, 30. Good chest rise.
So when the AED starts talking again, Jacob, we're just going to swap over, alright? So I've got my suction unit here, just so in case my patient vomits, we can log roll him and clear that vomit out of his airway. It's important to remember with ventilation, the MOANS acronym, so making sure that the mask seals properly in place. Someone who's obese can be more difficult to ventilate. Age, if he's got no teeth, it's also more difficult, or if he's snoring or has a stiff neck. So Cameron, what's been going on today?
Yeah, so we were just in the mall and I don't know, something's just happened and he's just collapsed and yeah, we just didn't know what to do.
Do you know if there was any bystander CPR?
No, we were just standing there and didn't know what to do. We called for the ambulance straight away, but you guys got here pretty quick. It probably only happened 5 minutes ago.
25, 26, 27,
Just a minute,
28,
Cameron.
29, 30.
1, 2.
Good chest rise.
Cool, so there was no bystander CPR, and with a longer period of no CPR immediately after a cardiac arrest is likely to not give a positive outcome. And because he didn't drown, he just collapsed, more likely to be a primary cardiac arrest than a secondary cardiac arrest.
25, 26, 27, 28, 29, 30.
Stop CPR. Analyzing heart rhythm.
Oops, it's just-
Stay clear of patient. Shock advised.
So you just want to push it when it says shock the patient? It said shock advice.
Yep.
Deliver
Yep, stand
shock
clear.
now. Press shock delivered. Pause. Start CPR.
Twenty-five, 26, 27, 28, 29, 30.
Yep.
This airway adjunct is known as an OPA, or oropharyngeal airway. The purpose of the OPA is to hold the tongue away from the posterior oropharynx. This prevents the tongue from obstructing the epiglottis. To measure an OPA correctly, you place the OPA against the patient's cheek, and you want the OPA extending from your patient's mouth to the angle of their jaw. To then insert the OPA, you want the curve facing your patient's soft palate. You then rotate 180 degrees and drop the OPA over the back of the tongue, holding the tongue in place. Benefits of an OPA are that it prevents obstruction by the lips and teeth. It also serves as an effective bite block and helps manage an unconscious person who is spontaneously breathing or needs mechanical ventilation. However, a serious contraindication of an OPA is that it cannot be used in a conscious or semi-conscious person who has a gag reflex. This is because this may induce vomiting, which could cause aspiration. Other serious disadvantages of an OPA is that an OPA cannot be inserted if your patient has clenched teeth. It does not prevent ventilation, and if the gag reflex was to return while the OPA was in place, this may produce vomiting, which could cause aspiration. Thanks. So I have a suction unit here because my unconscious patient has vomited into his mouth and he needs assistance removing the vomit. I've placed him into the lateral position because if he was to remain to the supine position, vomit could continue to obstruct his airway further. Before I insert the Yankauer into his oropharynx, I'm going to test the suction unit itself to make sure that it can generate enough pressure. So I'm turning it on to full and kinking to the tube to make sure that it reads above 350 millimeters of mercury. When I insert the Yankauer into my patient's oropharynx, I'm only inserting it in as far as I can see, and it's going to remain in there for 10 seconds and no longer. If you keep the Yankauer in the patient's mouth for longer than 10 seconds, you risk the chance of increasing chances of a hypoxia because you cannot properly ventilate your patient while the Yankauer remains in his mouth. So turning my suction unit on. suctioning only as far as I can see and rotating as I remove the Yankawa out of his mouth. If I was to troubleshoot if something got stuck in the Yankawa, I could use water to help remove it. Upon primary survey, the patient was found to be hemorrhaging from a lengthwise laceration on his arm. This was the immediate threat to the patient's life and required critical intervention. My first step in the treatment process of hemorrhage control would be to expose the wound. Now that the wound is exposed, I would wash with saline if necessary. If my patient's wound was contaminated with debris, it would be necessary to wash with saline. For the purposes of this video, I don't have a bystander or colleague to ask to come and elevate the arm. However, if I did, I would ask someone to elevate the extremity because elevation allows gravity to slow down blood flow to the area. I would then apply direct pressure using the two-finger method. Direct pressure helps to constrict blood vessels manually and further stem blood flow to the area. I would then apply a dressing. Dressings promote hemostasis, protect the wound from further mechanical damage and immobilize tissues. I would then bandage over the wound, twisting and tightening as I go, as this further applies direct pressure. Despite attempts to manage this patient's wound with wound care, it continued to hemorrhage, so a tourniquet must be applied. Once a tourniquet is applied, it should not be removed until the patient reaches hospital, as lack of perfusion causes lactic acid, potassium, and other metabolites to build up in the stagnant blood. If a tourniquet was removed, these metabolites could enter central circulation, and this could have life-threatening consequences for the patient. My first step would to be to inform the patient that a tourniquet needs to be applied and gain consent. I would then offer analgesia, and the analgesic that I would offer would be Entonox. The contraindications of Entonox are if you have been scuba diving for less than 24 hours, unable to obey commands, suspected pneumothorax, or a bowel obstruction. So I'm now going to apply the tourniquet. A tourniquet must be applied 10 centimeters proximal to the wound, and it cannot be applied over a joint. Now that the tourniquet is on, I'm going to tighten the windlass. If the windlass needs to be tightened more than twice, the tourniquet has not been applied tight enough. I would now document the time of tourniquet application, and if the wound continues to bleed, I would apply a second tourniquet proximal to the first. This airway adjunct is also known as an NPA, or nasopharyngeal airway. A nasopharyngeal airway follows the natural curvature of your patient's nasopharynx. It passes through the nose, extending from the nostril to the pharynx just below the nose. When measuring an MPA, or to measure an MPA correctly, you want to make sure that the MPA is slightly smaller in diameter than your own patient's nostril. You also want to make sure that the tube covers the distance from your patient's nose to the base of his earlobe. Upon insertion, you want to make sure that that the MPA is well lubricated before you insert the tube, because this decreases chance of tissue trauma and epistaxis. When passing the MPA into the nose, you want to make sure that you're inserting it in your patient's larger nostril, which in most patients happens to be the right nostril. It is important, if you encounter resistance while trying to insert the MPA, that you do not force the MPA into the nose, because this can increase chances of tissue trauma. Instead, just rotate the MPA gently. Important benefits of an MPA is that an MPA can be used in the presence of a gag reflex. However, if you think that your patient cannot tolerate a gag reflex, an MPA, you must remove it immediately. An MPA can also be used if your patient's teeth are clenched. However, contraindications of an MPA are if you suspect that your patient has a basilar skull fracture. An MPA should be used as a last resort only. It cannot be used in a patient who has a history of epistaxis or a nasal obstruction. So today I will be assessing my patient's vital signs. I will be taking a blood pressure reading, a pulse rate, and I will also be taking respiratory rate. A healthy pulse rate in an adult is 80 beats per minute, and a healthy respiratory rate in an adult is 12 to 20 breaths per minute. A healthy blood pressure reading is 120 systolic over 80 diastolic. So the first reading I will be taking is a pulse rate. I'll also be taking the respiratory rate at the same time, so that my patient doesn't subconsciously change their breathing pattern when they're aware of me taking their respiratory rate. For the purpose of the video, I'll be taking a pulse rate for 15 seconds. However, the golden standard is to measure both pulse rate and respiratory rate for a minute. So you take the easiest access for taking a pulse is the radial pulse, which is on the thumb side of the wrist. So my patient has a healthy respiratory rate of 15 breaths per minute and a healthy pulse rate of 75 beats per minute. When it comes to taking a respiratory assessment, I will also auscultate for a healthy tidal volume and clarity. A healthy tidal volume in an adult is 500 mils. So could you please take a deep breath in? And again. In. Thanks. So I will place the blood pressure cuff on my patient's bicep so that I can auscultate the brachial artery. You want the artery marker just above the brachial artery, so it indicates where to auscultate with your stethoscope. Could you please stretch your arm out for me, please? So blowing up the blood pressure cuff, the first sound I will hear when the blood pressure cuff is released will be the systolic reading, and the last sound I hear will be the diastolic reading. So, and my patient had a blood pressure reading of 125 over 90, remembering that a healthy blood pressure reading in an adult is 120 systolic over 80 diastolic, so this is healthy.